I'm excited today for our panelists to speak with us about lung cancer screening essentials. So our first speaker is Dr. Jason Long. Dr. Long is an assistant professor within the UNC Division of Cardiothoracic Surgery, and he serves as the co-director of the UNC Lung Cancer Screening Clinic. He completed his general surgery training at the University of Chicago in 2011 and his cardiothoracic surgery training at the University of Michigan in 2013. His interests include surgery for lung and esophageal diseases, lung transplantation, minimally invasive surgery, including robotic surgery, and small lung nodule localization and resection. Our second panelist is Michelle Ottersbach. Michelle is a nurse navigator, an exercise physiologist, a lung cancer health advisor, and a lung cancer screening program consultant. She currently works with the UNC Lineberger Comprehensive Cancer Center's lung cancer screening program. And she completed her doctorate in nursing practice in 2023 from the University of Cincinnati. And our third presenter is Dr. Kim Shoenbill. As the director of the UNC Tobacco Treatment Program, Dr. Shoenbill is strongly committed to evaluating and optimizing tobacco use treatment interventions. She is an assistant professor in the Department of Family Medicine, director of the UNC Clinical Informatics Fellowship Program, and faculty member of the Program on Health and Clinical Informatics. She also completed her PhD in clinical investigation and National Library of Medicine postdoctoral fellowship in biomedical informatics at the University of Wisconsin-Madison. So welcome to our presenters. Thank you for being here. So here is a sample of our first Poll Everywhere question. This is what it will look like on your screen. You can go in and practice at pollev.com, UNC-LCN. So our first question is, lung cancer screening is recommended only for adults who are at high risk for developing the disease. Here are our disclosures. And you should be able to enter on Poll Everywhere. So lung cancer screening is recommended only for adults who are high risk for developing the disease. True or false? How's our audience doing?
I'm waiting to see.
Only false. Anybody out there want to hit true? So I will pass it on to Dr. Long to kick us off for lung cancer screening essentials.
Thanks, Tammy. And thank you everyone for attending our discussion today. I will be talking a little bit about why and who to screen. And by doing that, I'm going to review some of the lung cancer screening trials that are important for lung cancer screening, in addition to guidelines, recent modifications, and some of the efforts to reduce screening disparities. Tammy, I guess we'll start with this question, is that right?
Yeah, it's here. So our next Poll Everywhere question, in your opinion, what are some of the challenges facing lung cancer screening? So you can input your answers into Poll Everywhere. I will chime in and say, I think it's when it's difficult to sometimes have patients show up for their screening and come to appointments. And
yeah, and I think this may be a little bit of an open-ended question, and maybe this will be a question for discussion at the end of the presentation. Shall I proceed?
Yeah.
Okay. All right. So just a few tidbits about lung cancer. Unfortunately, it is the most deadly disease in terms of cancer in the United States. And there were 235,000 cases, new cases in 2021 with 131,000 deaths. Specifically in North Carolina, there were over 9,000 cases last year of lung cancer, and it accounted for approximately 26% of all cancer deaths in North Carolina. We all, I think, have a basic understanding that the sooner you find a cancer, especially lung cancer, the better off survival will be. So the earlier stage you find a lung cancer, the better survival will be. Early stage disease is treated with surgery. Probably one of the most important trials in regards to lung cancer and lung cancer screening came out in 2011 in the New England Journal of Medicine. And this was the National Lung Screening Trial. And the objective was to determine whether low-dose CT could reduce mortality from lung cancer as compared to normal chest X-ray. The study was basically randomized patients are high risk for lung cancer to get a chest X-ray annually or low-dose CT, and we'll explain more about what low-dose means in a few slides ahead. Patients who were considered high risk for lung cancer at this point in time are age 55 to 74, who smoked more than 30 pack years, meaning 1 pack a day times 30 years. And had quit within the last 15 years. The trial was large. It consisted of 53,000 patients, about 26,000 in each arm, and those who underwent each respective radiologic study were then followed for 3 annual screenings. And to sum up the study in a few slides, basically low-dose CT found a higher number of cumulative lung cancers compared to chest X-ray. And this translated to a cumulative number of less death and less mortality compared to chest X-ray. And this really set off the momentum for lung cancer screening programs across the United States. So the results essentially showed 20% reduction in lung cancer mortality and 6.7% overall mortality. 50% of the tumors that were identified were stage 1, which is important for survival. And we found a phenomenon of stage shift, meaning screening increases the number of diagnosed early stage lung cancers. And specifically on low-dose CTs, we found 40% stage 1A cases, which is essentially the earliest stage lung cancer, compared to 21% in chest X-ray. Fewer patients were diagnosed with advanced stage disease as well. The other important phenomenon we noticed was a pathologic shift. And low-dose CT identified 110 patients with bronchoalveolar carcinoma, and that's an older term that has now become antiquated. And if you look down below the slide, really what we're talking about are early pre-invasive lung cancers or very early invasive lung cancers. And we found more of these in the low-dose CT group, which translates to better survival. So for example, this is a CT scan of the chest. We have an axial and a frontal view of the chest. You can see a large right upper lobe lung mass, which is the white mass in the right side of the chest. This is a typical advanced stage lung cancer that may or may not be treated with surgery. But what we're finding on low-dose CTs and in screening patients are these smaller nodules. So this is another CT scan with you can kind of see that gray, cloudy nodule density in the left lower lobe of the lung. That's called a ground glass opacity. And really what that means is it's a imaging finding. And if you were to touch that lung with your finger, you would not be able to feel it because it's not solid. It's only identifiable on CT scan and really hard to identify on chest X-ray. This is another example of a ground glass opacity in the right upper lobe of the lung. And this is a ground glass opacity with a part solid component, meaning it's the white portions that are solid. So if you touch that with your finger, you may be able to feel something pea-sized. This is another example of a left upper lobe part solid lung nodule. Again, you have a solid component, which is more white and dense, and the non-solid component is kind of gray, cloudy. And these are typically what we see on low-dose CT scans. So as a result of this trial, the USPSTF task force recommended that all patients aged 55 to 80 who are current or former smokers within 15 years and with a 30-pack year smoking history should receive annual low-dose CT lung cancer screening. So since that time, what has been going on in the United States with regards to screening? Well, unfortunately, there's very limited uptake of lung cancer screening. So in this study that was released in 2019, approximately 14% of all eligible patients across the United States actually received a low-dose CT. And there was variability from state to state, with some states doing better than others. In addition, we're seeing variability within states. This is an interesting study in the Annals of Thoracic Surgery looking at the state of Virginia. And the colors represent areas of percentage of smokers in Virginia. And you can see in Southwest Virginia, where there's plenty of red and orange, that's the highest density of current active smokers. Whereas in Northeast Virginia, near Washington, D.C., that's the lowest density. The black dots represent official low-dose or lung cancer screening programs available in those areas of the state. And the open circles are areas where there is demand for low-dose CT screening. And you can see that they are mismatched, and this is common across the United States and even our own state, North Carolina. This is a paper written by Louise Henderson, who is a researcher here in Lineberger with lung cancer screening, who essentially wanted to look at uptake of low-dose CT across the United States using Medicare fee-for-service populations. And so the top map is the United States with the estimated lung cancer screening eligible Medicare population. So you can see that the most density of patients who need low-dose CTs are in states like Kentucky, Tennessee, West Virginia, even our own state, North Carolina, Arkansas. However, on the bottom, that's actually the estimated lung cancer screening eligible Medicare population that received a lung cancer screening CT. So again, mismatch not only in the states, but across the country. There has been another very important pivotal trial, it was a randomized trial performed in the Netherlands and Belgium. And this is called the Nelson trial. And it was basically they wanted to show a reduction in lung cancer mortality with volume-based low-dose CT screening in high-risk male participants at 10 years follow-up. And we'll get back to that about why male and not female. It was a randomized trial, and they also examined patients at high risk for lung cancer with a slightly different definition, similar age profile, greater than 15 cigarettes per day for 25 years, or 10 cigarettes per day for 30 years. And they screened at intervals of 1, 2, and 2.5 years. And they used something a little bit different from the previous trial, and that's nodule volume automated software, which can look at a nodule and estimate the volume. And may be a more accurate way to estimate the risk. So in this trial, they saw, again, a significant reduction in lung cancer mortality in men. There was a small subgroup of women participants, and they actually showed an even greater benefit in lung cancer reduction mortality. Because of the volume-based imaging, they found less false positive tests, meaning nodules that appeared to be suspicious but are not actually positive for cancer, which translates to less invasive procedures, less biopsies that are not needed. This was more beneficial than we saw in the National Lung Screening Trial. And importantly, the subgroup of women participants showed greater benefits in terms of lung cancer screening than in men. And there's not only gender disparities in lung cancer screening, which was evident in the Nelson trial, there's also racial disparities. Unfortunately, the National Lung Screening Trial only included 4% African-American smokers. And African-American men on average smoke less cigarettes per day compared with white smokers and have lower overall smoking pack year history. However, African-American smokers have a higher risk of lung cancer compared with white smokers for the same quantity of cigarettes per day, as well as fewer smoking cessation attempts. So the mean age at lung cancer diagnosis occurs significantly early among African Americans. This study was in the JAMA Oncology. It's a very good paper. I definitely recommend reading it. This is also another paper that used the 2013 guidelines for screening, but applied it to a different patient population. And these are white and black smokers in the South. And basically what they found was a higher percentage of African Americans who had lung cancer, but were not eligible by the 2013 guidelines. So because of this, the guidelines were expanded in 2021, and the age was decreased to 50. So it included adults age 50 to 80 to account for African Americans and women who are younger when they get lung cancer. And also reduced the smoking pack year history to 20 instead of 30. Because of this, 14.5 million U.S. adults are eligible for lung cancer screening. That was an increase of 81% compared to prior, and a higher relative increase in eligibility of women versus men and of Blacks, Hispanics, Native Americans versus whites. And we also see greater gains in lung cancer deaths averted and life years gained in women compared with men. However, there still remain some barriers and issues. Current guidelines really do not account for patients with HIV, and lung cancer is the leading cause of cancer-related deaths in people with HIV. Prior cancer survivors, such as head and neck cancer, urothelial cancers, et cetera, are at higher risk for developing a primary lung cancer than the general population, and this is not really addressed in the current guidelines. In addition, known risk factors for lung cancer, including radon, air pollution, asbestos, secondhand smoke, inflammatory lung disease, and occupational exposures, are not accounted for, and may be to a degree, but could be more specifically. And then there are plenty of patients over 80 years of age who are healthy enough to be screened to undergo treatment for lung cancer who are still at risk for lung cancer. And this currently is also not assessed by guidelines. And as of last week, there have been further updates to lung cancer screening by the American Cancer Society, which essentially did away with how many years you've been quit. So now all people 50 to 80 years of age who have smoked 20 pack years, regardless of when they quit, are eligible for lung cancer screening. I just have a few more slides and we'll move on to the next speaker. Some important facts about lung cancer screening. CMS coverage for annual low-dose screening requires several important things, one of which is documentation of shared decision-making, which means discussing the risks and benefits of screening, false positives, diagnostic procedures, and the harms that it could cause. We also need to discuss tobacco cessation counseling, which Dr. Shoenbill will discuss. Low-dose CT essentially means a lower dose of radiation compared with an average diagnostic CT scan. And this is estimated to be about 1.5 millisieverts per exam compared to 8 millisieverts for a diagnostic chest CT. This is important because patients will be receiving annual scans for many years potentially, and increasing incremental doses of radiation can also cause harm. All low-dose CTs are interpreted with a lung-rad score, and Michelle will speak a little bit to that, but it's a structured reporting system that defines what constitutes a positive screening test and links to care pathways. Every single low-dose CT you order will have a lung-rad score assigned to it, which will help guide the next steps. This has been shown to improve and standardize lung cancer screening performance, improve patient outcomes, and decrease false positive rates. So a little bit about our program. Dr. Patricia Rivera and I co-directed this program for several years, and unfortunately, Dr. Rivera moved along to a separate academic program, and now I'm the director of the lung cancer screening program, and we have a multidisciplinary team consisting of interventional pulmonary, radiology, family medicine, primary care, as well as radiology and epidemiology. We have a centralized lung cancer screening clinic located at Easttown here in Chapel Hill, where we perform low-dose CTs at the same time as a clinic visit to discuss the results. This is on Thursday afternoons. We also are continuing to update our website. We have named ourselves the UNC Early Detection of Lung Cancer Program, which includes not only lung cancer screening, but also incidental pulmonary nodules. They're all housed under one program. Our contact information is on this website. We also have a multidisciplinary pulmonary nodule board every Monday at 3 p.m. It's a virtual nodule board where we meet up with CT radiology, thoracic surgery, interventional pulmonary, and primary care, and we discuss any incidental pulmonary nodule in addition to any lung rads 0, 3, or 4 patient who needs multidisciplinary discussion about next best steps. There is an order set in Epic on ordering low-dose CTs. It's under CT lung cancer screening. There are a number of variables you have to fill out that are important. One of which is, have you discussed shared decision-making with the patient, yes or no? Does the patient have any signs or symptoms of lung cancer? This is important because if they have signs or symptoms of lung cancer like cough with hemoptysis or coughing up blood, chest pain, weight loss, anything that's concerning, they really should be seen and get a diagnostic CT. And then it also asks if this is a low dose versus routine CT. It's always low dose. And then have you discussed smoking cessation and placed a referral for that? This order set does have some challenges, and we are working to improve this. You will see changes in this in the coming months. There's also a website called shouldiscreen.com, in addition to others, where you can actually assess the risk a patient may have for lung cancer in the next 6 years. And this is important because a lot of lung cancer screening programs are moving towards a risk-based model. And essentially what that means is we take into account age, race, gender, education, BMI, COPD, family history, smoking history, and that provides a 6-year risk of developing lung cancer. And in many programs across the country, and according to NCCN guidelines, a risk greater than 1.51% is improved sensitivity to 75% compared to the USPSTF criteria. So a lot of programs are moving towards this model. I would say our program may eventually do this as well. All right.
So we have our next question. So a 56-year-old construction worker presents to your office for a regular office appointment to follow up with her diabetes. During your assessment, you notice that she is currently smoking with a history of chronic bronchitis, occupational exposures to diesel fumes, and shortness of breath and cough that has not changed in the past 12 months. Her last chest CT was a low-dose CT screening 15 months ago with a lung RADS2 recommendation for stable nodules. What would you recommend?
Michelle, do you want to maybe provide some guidance on that?
Yeah. And I'm sorry, we are not seeing the poll everywhere question populate there. There we go. All right, thank you.
Thank you. We'll allow a few seconds, I guess, for response.
Yeah, thank you for your patience. So you can go into poll everywhere to respond with what you would recommend for that patient. Great.
Okay.
So
do you want me to give the answer?
Sure.
Well, do we order a routine chest to evaluate the cough and shortness of breath? Well, it's stable for 12 months, so probably not, right?
Agreed. I think this patient's would be considered asymptomatic.
Yep. Order a 12-month low-dose CT, and the CPT 71271 is the preventive code. So that's what's, so that's an option.
Okay.
I mean,
and maybe, Michelle, could you explain what the difference between the two CPT codes you listed there?
So we have two codes. We have the 12-month low-dose CT screening exam, which is CPT 71271. That is your preventive screening code. That if they meet eligibility, that will waive their copays. And there's some requirements there for that. The order for a 12-month low-dose CT screening follow-up exam is your diagnostic low-dose exam, and that's the CPT 71250. Because this person, we know they're currently smoking. Kind of a trick question, I guess. I didn't put the PAC years, but that was they're already enrolled in the program, so they had a low-dose CT 15 months ago. They had a lung RADS2, so we know that they're coming up due for their 12 months. So they're overdue. And so it's a time that we do need to get their yearly low-dose CT screening at the 71271. So B is correct. We don't want to do C because we know that they're eligible. They're currently smoking, and they do. It is well, I didn't put it in there, but it is. They're a 20-pack year history because they're already enrolled in the program. Since they're currently smoking, you should be discussing smoking cessation interventions with them. And so the answer is G.
Okay.
Okay.
Great.
Oh. Did I go backwards? Okay. So in this part of the presentation, I will be talking about how lung cancer screening is a multifaceted program, the requirement for informed decision-making, and the essential role of navigation. As I speak, we have to remember lung cancer screening is not the low-dose CT, it's the program. The low-dose CT is an imaging study that is performed in the program, but lung screening is the entire process from outreach to getting your initial screening, shared decision-making visit, to the nodule management protocol on to diagnosis. So lung screening being the entire process. In your opinion, what are some of the challenges involved in setting up a running a lung cancer screening program? And cost is a barrier. So yes, it is, because we have to end up with the cost. We have to be able to find the resources to support the program. So, and to justify the program. And there are tools to help there. Everything from the lung map that the National Lung Cancer Roundtable can help you set up your budget. So that's available. Public awareness is a great one, because if we don't tell people that screening programs exist, they won't come. So we need to get it out there and tell them that you have a lung screening program, and we have to make it accessible and make it easier for them to call and schedule. So we don't want to run through all the barriers. So when they want to get screened, we need to make sure we get them scanned. Staff knowledge. So we do need to educate the providers, the nurses, the MAs, anybody who touches that chart, especially if you're doing a smoking history, to identify who is eligible and making sure they follow up. Commitment to return for future appointments. That's essential. Lung screening is a process, not a CT scan. So it's essential that when they enroll in the program, that we educate them to let the people know that this is just a one-time scan. This is not a one-time scan. We're getting the first scan to assess for spots on your lungs, and then we'll come up with a recommendation for you to come back to compare that spot or that lung nodule. Organizational recognition of need for change. Absolutely. If you don't have the commitment, if the program and the organization doesn't have the commitment to increase volume, you're not going to increase the volume. So it is essential to have an organization to recognize that there needs to be a change. I think I went backwards. Sorry. That was my fault.
No problem.
The components of a multidisciplinary program it has to be multidisciplinary approach, multiple disciplines involved. It's not a primary care program, a pulmonary program, a thoracic surgery, radiology. It's all of it. So everyone's involved as an equal partner. You have to establish program enrollment criteria, whether that is the ACS criteria, the NCCN, the USPSTF, and have protocols in place. Once you set your criteria, you have to identify eligible participants and how you're going to identify those. And one key, the ground part is, which Dr. Shoenbill will talk about, is comprehensive smoking history and smoking cessation counseling in the office notes, which we are all required to be doing anyway. The shared decision-making with the patient and their provider. And it's not a CT scan, so we have to make sure that we have a structured protocol in for reporting, not only the lung reds, but we have to make sure we follow a structured protocol utilizing low-dose CTs and other follow-up according to a structured nodule reporting, nodule management protocol. And more importantly, the patient navigation. That helps get the patient in to be seen quicker and reduces cost. In your opinion, what are the disciplines that are involved in the lung cancer screening program, and what is the role in each? Most people will say, thoracic, radiology, pulmonology, but it is everyone. So it's everyone from the outreach coordinator, outreach team, that's going out to capture them, to the primary care and all the other disciplines that are seeing people in their clinic, So they see that they're eligible to get them enrolled in a program so we can effectively track and manage the people. Identifying eligible participants from a nursing perspective, particularly those that may not currently access the healthcare system. The main key is, which Dr. Shoenbill will talk about, is smoking history and smoking cessation and counseling. Your shared decision-making, talking to the patient, informing them about if it's appropriate to them, and navigation. And more importantly, teamwork. Without a team, you don't have a program. So you have to make sure that the team is working together as equal partners as a team. Shared decision-making, Dr. Long has already talked about it. It is a discussion between the participant and the provider on whether to enroll in a program. And so when they agree to enroll, they'll be see if it's appropriate. They'll be discussing the risk, benefits, and potential harms of the screening. And as Dr. Long had stated, there's a great shared decision-making tool out of the University of Michigan called the Should I Screen? And there's also the option that you can refer to the lung cancer screening clinic, and the lung cancer screening clinic can do the shared decision-making. In Epic, we also have a dot phrase called dot shared lung that you can actually insert the shared decision-making language. You can also, it is billable, and you can collect RVUs for it by putting it into your office note. So the billing codes for shared decision-making is G0296. Your diagnosis codes are your ICD-10 codes. You just, when you're talking about screening, you want to make sure it's risk factor space. It's either your current thing, an easy way to think of it is you're either currently smoking or you quit in the past, or a former smoker. So current or former. And so the Z87.891 tends to be for the people who quit. The F17.2 is for the current smoking, and that will apply for your Medicare, but you do get RVUs for that, which is about 0.54. Shared decision-making, here's a sample primary care script that Andrea McKee uses with her primary care physicians when they enroll them into her program to keep it simple. It's very simple. She uses this script for her primary care. It's heavy smoking may cause lung cancer, a deadly cancer that can be potentially cured if found early. Low-dose chest CTs is a proven way to find early lung cancer, is recommended just as mammography for breast cancer, pap smears for cervical cancer. CT imaging may be a falsely detected something that does not turn out to be cancer, but this really rarely happens. And there's less than 1% for invasive procedures for benign. And the benefits of detecting early lung cancer outweigh any risk. I strongly urge you. So you can keep it simple and personalize it like that. It doesn't have to be an hour-long talk. So you can keep it simple like that, and then you can refer them into a program. Lung reds, it's the nodule reporting, it's a structure reporting nodule management protocol used for the lung cancer screening population that keep it standard for the low-dose lung screening exams and the follow-up CTs in the program. And it goes by this is Lung Reg 2022 by the American College of Radiology. You have your orders. You have your CT lung cancer screening order, which is the ones that are billed as preventive, which is 71271. These are your baseline low-dose CT, which is the initial one, and the 12 months. And your ICD-10 code to get this covered for people who meet USPSTF guidelines for the commercial payers, and the Medicare guidelines for the Medicare payers is right here, which is the same as your shared decision-making code, which is the Z87.891, which is for those that are formerly smoking or former smokers, and then the F17.2 series of lists for those who are currently smokers. The CT lung cancer screening follow-up, that's when they recommend for a short interval, because this is for nodule management and tracking. Keep it simple, and your ICD-10 code is something like pulmonary nodule or whatever. So that's kind of simple. You can keep it simple. There'll be other findings on there that when you read the report, you'll know what to put in. But that will trigger insurance to bill it as a diagnostic, and they will have they may have a deductible or copay depending on their health plan and their secondary insurance. But for the first one, the 71271, if the commercial plan for the U.S. Preventive Service that'll follow the Affordable Care Act, that should not generate a deductible copay, so it should be waived. The key to navigation, they serve as a system navigator for people at high risk and underserved populations for lung cancer. They serve as a system navigator for people at high risk and the underserved population for lung cancer and the multidisciplinary team. As navigators, we work for the patient, and we work with the disciplines to make sure that the patient gets where they need to go. You're the expert. You need to be aware of your physician protocols, make adherence to the physician protocols, and the revenue cycle best practice. So if the advanced practice providers or the referring physicians have issues and you may be called in to get some to authorize some low-dose CTs, short interval or baseline or annuals. They help enroll the people into the program, make sure they meet the eligibility based on your program. Program consent, that's just letting them know what to expect in the program. It's not a one-time scan. They're enrolling into a program and we'll be following across a structured protocol. Navigation may be involved in insurance authorizations, billing, and then if there's denials, you can help get that covered. So it's a complex. So navigators do wear different hats. We're not all nurses. So it's anybody who is navigating that patient throughout the system from outreach to coming into the imaging center to results reporting to diagnosis. We'll be providing education, care coordination. We need to get them timely access to, if they don't have a primary care when they're enrolled in the program, you have to be able to get them in to primary care to establish primary care. To also tobacco treatment programs and other resources. If you find when they're due for their follow-up or their next scan, you're also there to encourage them. Make sure they're following up with their primary care, getting their annual wellness visits, because the key is to establish that relationship with the primary care. The primary care can help you, and you can kind of work together to help remind them if they're overdue. You're responsible for longitudinal tracking of the people and the outcomes for the multidisciplinary team to make sure they're getting the data they need for continued quality improvement. As a navigator, it's important that you review the radiology reports, adherence to evidence-based practice, as well as office notes, so you know what the next follow-up is. So just make sure that the physician gets a radiology report, find out what the physician recommends based on that report and their medical evaluation, and make sure they come back in when they're supposed to. And also, you want to be actively involved in clinical administrative meetings so you can help your medical team, your physician team, to improve care. And I'll turn it over to Dr. Shoenbill, who will be talking about smoking cessation.
Great. Thanks, Michelle. Can everyone hear me okay? Can you wave at me if you're good? Okay. So I always like to give people a mental map as I start any type of discussion so you know where we're headed. So first we'll talk about smoking cessation and the lung cancer screening program. We'll have a little discussion of some upcoming changes to EPIC, which I'm sure everybody is just so excited about on this call. And I know I am. And we'll have some review of the literature on the efficacy of tobacco use treatment, and then I'll give a little overview of the UNC tobacco treatment program. So we'll turn this back to Tammy.
Our next Poll Everywhere question, in your opinion, what are some of the biggest challenges with patients and smoking cessation? You can input your answers to Poll Everywhere.
Long-term commitment, yep. It is a process and has to be addressed repeatedly. Talking with patients about smoking cessation, that can be a barrier in a busy clinic practice, absolutely. Readiness to change, yes, and helping patients get closer to that. Access to resources, absolutely. This comes with some of our disparity issues. Social support, absolutely. Those social supports within that patient's environment can be key to their success or failure. All right. So I think that we have a good smattering of some of the challenges that we see. We'll talk a little bit more about this in detail. So first, tobacco use, it is a call to action. In North Carolina, we have an adult smoking or cigarette use prevalence of 18.5%. We are not the worst across the continuum of the states, but we have much room to move to get closer to that 0%. Smoking prevalence in patients with cancer is on average 87%, with males being a little higher, females a little bit lower. For lung cancer projections for 2023, 238,340 new lung cancer cases. If we break this down by the percentage that are due to smoking prevalence, we have about 650 new cases per day on average, and then 570 of those are due to smoking. We have a lot of work to do. Additionally, we have deaths from lung cancer screening, projections of 127,000 for 2023. Of that, 350 deaths per day, with 300 deaths per day due to smoking. I want to pause and have everyone think about that for just a moment. If we had an airplane crash, as an example of a recent lecturer that came to us, if we had an airplane going down every day with 300 deaths, we'd be up in arms. We would be talking about what can we do better? And unfortunately, a lot of these deaths go unrecognized, and they are preventable. And as a healthcare system, we do need to do better. So who should be referred for tobacco use treatment? All patients with either current tobacco use, and that's easier to identify, but also patients who have past tobacco use and they're still needing support, because tobacco use is an addiction. Tobacco use does require ongoing support for abstinence. So we want to make certain that we are catching them, and they are more difficult to catch. So we have to have those conversations in our offices. Our UNC approach is an opt-out model. I have a little graphic there. So in an opt-out model, everyone is permitted to come to counseling. Everyone is encouraged to come to counseling. We reach out to everyone who's identified as a current smoker. And then they have to actually say, no, I don't want those services right now. As opposed to an opt-in model we don't use, which is everybody's denied services or not offered services in the beginning, and they have to actively come to us and say, hey, I'd like this service. Much harder to put something else on the patient's plate. So we do use that opt-out model here at UNC for our tobacco treatment outreach. We do outreach actively to patients with current tobacco use. That cohort of patients who are former smokers but may still be at risk of going back to smoking. We don't have a good capture system here from an opt-out perspective, but we do need to work on that. To the tobacco treatment outreach to patients with current tobacco use, we have a Tell-Ask Quit Plan Manager. This provides automated triage to patients, and they can either choose to have a referral to the tobacco treatment program or quit line if they're interested in services, or they can also take a pass and opt out. We also have referrals via patient or providers actually putting in the EPIC referral for us, and then we prioritize those patients in our daily schedule to reach out to them first. And I just want to address a myth that patients who are not ready to quit should not be referred. That is a myth. So you have to understand that there is significant power in motivational interviewing and setting up patients with short-term goals, getting them to identify what could benefit from quitting or cutting down by just one cigarette per day. What are your goals ultimately that might be in line with cutting down or quitting tobacco? So even if they say, I love smoking, I'm not ready to quit, having that conversation can put them one level up to actually cutting down and quitting in the future. So it's still important to have that referral in place. So I do want to share those exciting upcoming EPIC tobacco documentation and lung cancer screening supports. So from the tobacco use documentation side, we are one of the pilot sites that has automatic tabulation of pack year history, which is so exciting because this is very difficult for a busy provider to do on the fly in their office with so many other competing priorities. And there is a hard stop. If a future provider is trying to get rid of a patient's tobacco use history by putting in that they're a never smoker when in fact they've had a 10 or a 20 pack year history, a red flag will come up to say, are you sure? So you have to actively override that if you say this patient was incorrectly identified as a smoker, as opposed to sometimes it happens that someone comes in and says, I'm not smoking, and somebody wipes out their entire prior history because they're not smoking that day. And then for the lung cancer screening module capabilities, the one that is currently being built is slated for an aggressive release December 4th. We're pretty excited about that. We'll see how close we get to that. The first task is to provide a best practice advisory for lung cancer screening, so identifying patients automatically who may be eligible for lung cancer screening and presenting that to the provider to say, yes, this patient should be referred, and then providing them with an easy way to make that referral happen. Within that, we have shared decision-making visits and tools to assist, scheduling tools to assist, lung cancer screening coordinator dashboard, which will allow our navigators and our coordinators to follow these patients long-term and make certain that they're getting in on time and getting appropriate follow-up for lung cancer screening. And then we also, hopefully in time, will have the patient self-scheduling through MyChart, and then we may have further build-outs that are listed there. So I just wanted to talk a little bit about a prior study that was done here at UNC with actually looking at what patients report on their tobacco use and how they interact with tobacco use treatment within the healthcare system. So from their words, when they come in for visits, they sometimes feel shame and isolation regarding their tobacco use. They're worried about their risks. They will acknowledge that they still enjoy this despite that, so that comes in the shame. And they also talked about the inconvenience of smoking. When they talk to the providers, they actually expect providers to bring this up every visit. Even though it sounds like we are annoying them and nagging them, they think that it is important. They know it is important. They do know the risks. These are smart people, but it is an addiction. And so they want somebody to actually reach out and just say, hey, how are you doing with your smoking? When you're ready, when you want to talk to our counselors, please let me know. We can do that today. They want that conversation to be had, and they want it to be had every time because they know it's important. They trust and respect their providers, so they're looking for some guidance from their providers. So you are in the driver's seat to talk about this with them. And they also want positive and target messaging. So with the positive, they don't want to be told all of the risks all of the time and it always to be a grim discussion. They want to know, what are they gaining by giving up cigarettes? And if you can frame your messaging in that way, it is much more powerful. They want to have more dialogue around this. They want an addiction model to be instituted so that people understand that this is an addiction. It's not a choice. So there's less stigma around this. And then related to lung cancer screening, they do want to have patient-centered outcomes and that shared decision-making to be talked about. So unique opportunities and challenges with pairing tobacco cessation and lung cancer screening. We want to take advantage of those teachable moments. Patients who are meeting criteria for lung cancer screening may also have greater motivation to quit, especially around times of other hospitalizations for COPD or cardiac disease. We want to take advantage of that. We want to understand that there's a lot of guilt and fear and shame and sense of futility. And we want to make certain that we reframe avoidance of interventions for tobacco cessation or lung cancer screening, that they want to avoid that because they're trying to protect themselves. And actually going forward with those treatments is more protective of themselves than avoiding them. We want to be conscious of their environmental and social triggers. A lot of patients who smoke have friends and family who smoke. That's a huge trigger. A lot of environmental triggers at their homes. We want to problem solve with those patients and partner with their social support network on how to minimize those triggers at home and in their working and social life. And then we want to be cognizant of the fact that these patients have high levels of addiction. So not only addressing the physical, but also the emotional and social and relational components of addiction. So effective tobacco cessation treatment, again, taking advantage of that teachable moment every time we encounter it. We want to focus on patient-centered goals with that motivational interviewing. If you haven't seen this model of OARS for motivational interviewing, it's very powerful and very helpful. We also want to have proactive dual treatment. I have proactive because that's what I call it, because I don't want to wait for that person to get behind in terms of their treatment. I want to proactively talk to them about dual treatment, both behavioral counseling as well as medication. And with medications, nicotine replacement, long-acting and short-acting for the urges that we know will arise. We don't want them to get behind when those urges arise and then they feel powerless and they go back to smoking. And in terms of quitting success, the percent of the general population who smoke and want to quit is about 70%. Huge. Percent of general population with successful quit on their own, 7%. And percent of general population that quits without meds or counseling and remains quit at 6 months, 3 to 5%. By doing proactive dual treatment, we can triple their chance of quitting. Again, fabulous. We still have a lot of room to move there, though. We did do a survey here at UNC from our inpatient team side, and patients who were seen by our inpatient team, 90% of them quit or cut down when we contacted them 3 months later. That's fabulous. We admit there may be some bias in there. We did have some patients who made no move there. They still were smoking or no reduction at that 3-month marker. So we know that although it may be skewed, we did get a sampling of that whole population. And here at UNC, we see patients from over 70% of the counties in North Carolina. Our outreach is huge. We have 4 branches of our tobacco use treatment program, and that includes an inpatient, an outpatient, a Lineberger Comprehensive Cancer Center, as well as an employee health arm. So we can meet any patient where they're at, and we can help them as they move forward in their tobacco cessation or tobacco risk reduction. And I will turn it back to Tammy.
Thank you. Thank you to our panelists. This was a great webinar on highlighting this very need for lung cancer screening. So you can, here are references, and if you have questions for our panelists, please put them in poll everywhere. We have a few minutes to chat, so we are open for questions. I will start us off probably for Dr. Shoenbill. Behavior change, you highlighted here a big challenge. Tips, advice for those that don't necessarily, we're not involved with lung cancer patients, other cancer patients, or, I offer the tobacco cessation program to every smoking patient I have. The amount that will allow me to put a referral in is less than 25%. I mean, very few will even okay me putting a referral in. I just want to get them to you all. So any advice, tips on what I can do or what other APPs or providers our team could do out there to just let us put the referral in?
Yeah. And just to be clear, as we talked about already, but I want to highlight is the fact that we have a safety net because it is an opt-out model that we have. So even if you don't get the referral in, we still will contact that patient on the backside. We won't badger them. We'll contact them once, and if they say no, we leave them alone for 6 months, and then we circle back again if they're still identified as a current smoker. So there is a safety net that they will get an outreach, which is fabulous. In terms of trying to motivate them there in front of you, trying to use some of that ORS technique. So we're trying to identify something that's important to them that they could take advantage of by stopping smoking or cutting down. So a lot of patients, I get winded when I play, soccer with my grandkids, and I kind of hate that, and it makes me feel old, and I'd love to be able to play more with them. But you know what? If you even cut down by 5 cigarettes over the next few months, you would start to feel better, and you would start to feel better really quickly. And I'm not saying you have to quit. We're not there yet. It takes a long time. This is not something that we're doing overnight, but why don't you talk to our specialists in this, and they can set up some ways that you can feel more supported, that you can actually have other things that you can do instead of smoking. They can help you talk about what are your triggers so we can try to minimize those for you. And if you're interested in medication, they can help you get set up with that for something that's individualized specifically for you to make this easier, because we know it's hard and we are here to make it easier when you're ready. And it can take multiple times. So starting early is really effective for long-term reduction and cessation.
Thank you. Our next question coming in, what are some patient behaviors that have caused you the most frustration, but that you and the patient were able to work through successfully? I'm assuming maybe that's for either tobacco cessation or maybe even I guess we could look at it twofold: tobacco cessation and getting in for lung cancer screening.
So
Dr. Shoenbill, you want to start that off?
I can give an example of a patient who, when we first started talking about some behavior changes, tobacco cessation being one of them, he told me on the backside that that day he hated me because I was going to take away his best friend, which was his pack of cigarettes. And I said, no intent to ever take away anything, but I brought up enough good points that he would have benefits for giving up his quote unquote best friend that it really made him think. So even though on the front side, he felt conflicted about this, on the back side, 1 year later, he comes back to me for follow-up of multiple things. And that practice I was leaving, and he actually brought me gifts and big hugs. And he was so excited on all the progress that he had made because we initiated the conversation. We started small, and he was able to move forward over the course of that year to become abstinent. He is a fabulous person, still stays in touch with me, and is still tobacco free. And even though I had every resistance along the path with him, I just hung in there with them. And I think that's the biggest thing. You show patients that you're there for them and that you will be there for the long haul, and there's no judgment as you're there for them, and they will keep showing that.
Yeah, great points. What about getting in for lung cancer screening?
Do you want to? Probably one of the frustrations, I don't really call them frustrations. It's you have to meet the people where they are. Sometimes it's a geographical location. They don't want to travel to a certain area, and you have to coordinate with their schedules. But you can coordinate with, if you see an Epic, wow, they're coming to see their primary care physician or another physician in your system. You can always work their appointments around that appointment. And also, I mean, you also have just to make sure, just educate them on the copays and let them communicate to you. So if they're getting bills, you want them to contact your navigator, because we can easily resolve these bills, but they have to let us know. And this, I mean, it happens all across the country. We just have to educate them before they get the screening. Hey, if you get a bill, contact the navigator. We'll take care of it, And so, and we have resources. So that's one.
This next question, I think, Michelle, you touched upon, but if anyone has something to add, are there opportunities to better coordinate care communication between lung cancer screening, providers, and other related care team members that the patients see? For example, primary care, pulmonology. I mean, you mentioned trying to coordinate patient visits, which I think is huge and a big challenge, but any other comments or responses?
I have to go back with when I was at the University of Cincinnati, we always, when there was results, when we sent the results letters, we always carbon copied. We would talk to the patient and say, hey, we want to make sure whoever was referring, we get permission. We want to give the keep their whole medical team up to date. So make sure when they enroll, every time they come back for the next low-dose CT, make sure you update that patient. Do they have a primary care physician? If they don't have a primary care physician, help them get one. They may need one soon. If they have a pulmonologist, make sure you know who their pulmonologist is, or a thoracic surgeon and medical oncologist. So it's easy to coordinate the care. So if your multi-D team recommends them seeing a pulmonologist, you may want to know that they already have an established pulmonologist. So it kind of helps, and you keep them all in the loop. And also, you don't get into that battle of who's ordering what. So you kind of keep them all on the same page. Yeah, we've got this, and making sure they all know. So the primary care is like, hey, who's going to order this scan, or the pulmonologist? And so he's like, we've got it, and this is and keep them all in the loop. So when they come back and complete their next low-dose CT, make sure you tell them all that they've completed it. Hey, we've got this taken care of, and I schedule the next scan.
And I would just, reflect back to Epic is being updated. So this will become easier for care coordination across the healthcare system. So stay tuned. Hopefully we'll have some even better supports built in electronically for everyone. And then I see the next question there. Are vapes and or nicotine patches recommended to help quit smoking? And I would just I would just like to do a shout out to Jeremy Finazzo, who is one of our tobacco cessation specialists at our lung cancer or our comprehensive cancer center arm. So he had responded, but vapes are not recommended for tobacco cessation. They have not been vetted by good evidence. Additionally, there have been difficulties with primary lung disease immediately from using vapes, as we all had seen a few years ago, and there's still a few trickling cases with that, with contaminants within them. Nicotine patches, absolutely recommended and encouraged, and that provides that baseline level of nicotine control. And then we also want to supplement with some short-acting versions with lozenges or gum so that patients have something to do when those urges strike despite the baseline nicotine. So yes, that is the recommended approach at this point in time.
I know we are past 5 o'clock. We will wrap up with this last question. If anyone has a short and sweet answer for it. For our Medicare patients that previously had not qualified for low-dose CT screening as they had stopped smoking greater than 15 years ago, but were eligible based on age, PAC year, and now meet eligibility criteria under ACS revised guidelines, how can we help with insurance issues until the task force revises their guidelines?
That's an excellent question, and maybe Michelle can chime in too. There's actually the American Cancer Society had a webinar on Monday that discussed some of these details, and a lot of folks asked this question. And insurance companies will lag behind the approval of these new guidelines. They will. So you need to be open with the patient about that, especially if you're going to enroll them into the program, that they may be exposed to cost. And it may take some phone calls to the insurance company as well, and good documentation of the most recent guidelines. Michelle?
Correct. I mean, correct. And it's really similar. I mean, we already had the same issue because the Medicare patients, 78 to 80, who quit within 15 years aren't getting covered. So follow the same process, because we're screening the USPSTF. So those with Medicare plans, the 78, 79, 80-year-olds, they're still not covered under Medicare. So follow the same process. You have self-pay rates. You can create screening funds to cover that population for your program, and go out and kind of recruit and just create some financial funds to help cover the cost. But yeah, like you said, do it by an individual basis with the health plan.
Great. Thank you to our panelists for sharing your time and expertise with us. Thank you to our audience for hanging in there with us. Thank you to the University Cancer Research Fund, to the Lineberger Comprehensive Cancer Center and the Lineberger Cancer Network, to our amazing telehealth team, to Tim, Benny, John, Oliver, Andrew, Patrick, Lindsay, and Barbara.